Good afternoon. Hope everyone is well today. This is Continuing Care 101. This is the third part in the series. In the first part, we covered interventions in the home, where we talked about home health and what affirmation does. We talked about helping hands. We talked about all those things and the ways people can get assistance in their home. And what are we doing the second one? I can't remember. Oh, what are we talking about?
What, second?
Oh, the levels of care. We talked about the levels of care in the second one and how the transitions occur, what are the different levels of care, and so we had a good session about that. And the third one, today we're going to talk about the rehabilitation household. And I think everybody knows about the rehabilitation household. I think when I first started working here, everyone referred to it as the Medicare household. And I figured out pretty quick that we should stop calling it that. We're going to call it the rehabilitation household. So I think we're going to have more of a conversation today. We're not going to be very reliant on slides, but I'm just going to open things up a bit to talk about why we're doing the rehab household and what the purpose of it is. And Adrian is going to talk, and Tamika are both going to talk a little bit about how the household will work. James and I are prepared to talk a little bit about the charges and how the money works and all that kind of stuff. Turns out it's a little complicated, so we can talk through some scenarios there. And then we'll just take your questions, and hopefully you'll leave today with a better understanding of the rehabilitation household. So a question I think some people are asking is, well, why are we doing this? We seem to have been fine for the better part of 25 years without a rehabilitation household. Why are we doing this? And the reason is because Cedarfield in its strategic planning, I don't know how long ago, identified that adding a rehabilitation house or aspect to Cedarfield would add revenue, and it would add non-independent living revenue. In other words, your monthly fees. It'll be a new source of revenue that did not involve your monthly service fees. And so the opportunity for additional revenue is one of the drivers for the rehabilitation household. Because we'll have the opportunity to take folks who don't currently live at Cedarfield and do some short-term admissions with them and bill Medicare. The other reason is because it's really a better value for you, because we will end up with a household or an environment at Cedarfield that is focused specifically on short-term stays. So it'll be the place where the focus of the household and the staff and the training and the oversight is more focused on rehab short stay, as opposed to sprinkling people in with rehab needs amongst a group of people who live in a household permanently. So that brings some advantage to you as a resident should you need it. When will the rehabilitation household be ready to operate? So it's currently under construction. The construction schedule has us opening that household in the early October time frame. So early October we should be able. It'd be nice if they finished a little early, but I certainly don't want to advertise that. But early October is when the household will be ready to go. We need to go through a process to get it certified as well as built, and certification is going to be in October.
Mm-hmm.
So really,
October, November.
Yeah. So the household will be ready to be occupied in October, early October, but then the certification process is looking like it may go on a little further, possibly into November. So maybe in the November time frame, our first person would stay with us under the auspices of Medicare Part A. All that good? Okay. I'm going to turn the microphone over to Adrian, and she's going to talk a little bit about her work with the household. She and Tamika will tag team on how the household will work from a clinical perspective.
Okay. Good afternoon, everyone. When the household opens, in the beginning, it will have current. I'm sorry. I can't, only because I've been exposed to people and you don't want me to. You cannot hear me?
No, we can.
Okay. She asked me to take my mask off, and I've been in areas where we're still in quarantine, so I don't want to do that to my ED or my business office manager.
Yes, request to stand.
Oh, you want me to stand up?
All these people said yes.
All the people behind the screen settings, behind the machine settings. Hello, how's everybody today? Okay, what I was saying was in the beginning, we're going to have current Cedarfield residents in the rehab neighborhood. No one's going to be displaced. That's where they'll live. And as they heal and move back to their IL apartments during their short stay is when we'll start bringing in community short stay people. And the purpose of that is for them to use their Medicare. And I'll let James get into the days and the money and things like that. And they're not going to be long-term care. They just come in, get their rehab for their hips or whatever their surgeries or whatever their issue is, get better and go home. Home being outside of Cedarfield if they don't live with us already. Any questions about that? I'm sorry? Okay. It may be. He just can't hear me.
She can't take her mask off.
Maybe you can use that one mic and just keep it. Just use the mic and keep it.
Adrian's not able to take her mask off, although I understand your request.
I'm going to try to hold it closer, but that's not the best I can do.
Does that help, Adrian? Okay.
Okay. So, as far as staffing, there will be a household leader for the rehab household, and there will be a clinical leader for the rehab household. You want to talk about how it's clinically going to be staffed?
Sure.
Hi everyone, I'm Tamika Ross. A little bit about the team members that we will have. The plan is to staff with a registered nurse on each shift. So that's something that we'll be working towards. We will have one nurse and 3 CNAs on the 7 to 3 shift, and one nurse and 3 CNAs on the 3 to 11 shift. And at night on the 11 to 7 shift, we'll have one nurse and 2 CNAs. So we've increased the staff in there. As far as preparation for this rehab household, it's a lot, but we have a lot of training and education that we'll be providing to our team members so that we'll be more than capable of taking care of the rehab needs or any need that we may have on that particular household. Do you all have any questions for me? Yes, ma'am.
And would you repeat? My understanding is this doesn't work for people at home.
Okay. We'll repeat the question.
Okay.
My understanding is the mic. Please repeat it anyhow. My understanding is we need 90% registered nurses, and based on what you said, that would be 1 registered nurse per shift.
Yes.
And 3 CNAs, that doesn't fit if I understand the Medicare requirement, and I may not.
Okay. It does fit the requirement.
If you'll repeat the question for the people at home that can't hear.
So the question was, with the 1 nurse and 3 CNAs, that it does not require them. It does not fit the Medicare requirement. That staffing model does fit the Medicare requirement. Actually, it's by star level as well. So at Cedarfield, we wanted to be able to provide the best service for you all. So we're actually, you only really need a registered nurse for 8 hours a day. And we will have a registered nurse for 24 hours a day. But we're only required to have a registered nurse for 8 hours a day.
And I believe the staffing for the CNA portion, I think many for-profit folks will get away with 12 to 1.
10 to 1, and
10,
we're doing 7
yeah,
to
10,
1.
11 to 1. And we'll be running about 6 to 1.
Mm-hmm.
So we'll have 3 CNAs on first and second shifts for a total of 20 people maximum, which comes out to 6.33 a person. So it's a very good ratio.
So I'll repeat that so anyone looking on TV can understand. So for our CNAs, we'll also be meeting that requirement with having the 3 CNAs for 60, which will take us to about, I'm sorry, I said 60, 20. So which will give them 6 residents. 2, 6, and 1, 7. So out of those 3 CNAs, 2 will have 6 and 1 will have 7. Yes, ma'am.
Okay, clarify something for me. If you're here under the Life Care program and say I don't want to use my Medicare, I want to use my Life Care portion, can I go to regular health care?
Yeah, so if you wouldn't mind, we'll keep your question and we'll hold it till we talk about the financial pieces. It's a good question, and we will answer it. If we don't, be sure to raise your hand. Not that you wouldn't, but it might be helpful just to go through a scenario or two. So here's how people might find themselves in a rehabilitation household. A person might be walking around their home and trip over the dog and fall down and break their hip. And you pull your pendant, we send you out, you get to the hospital, you have a broken hip, and they say, we're going to schedule you for surgery. And you're going to have hip surgery, or knee surgery, or elbow surgery, or whatever it might be. And you stay for 3 nights in the hospital, which is a qualifying stay for Medicare. They would say, you're not ready to go home. We would like you to go to a rehabilitation center. And you could go anywhere you want to go, but it would make a lot of sense for you to come back to your home at Cedarfield. And all these 25 years, you've been coming back to any available room anywhere in the healthcare area. But the difference will be now you'll come back to a rehabilitation household that is more geared towards rehabilitation than it is providing long-term care services. You would stay there, you would receive rehabilitation and medical oversight and all those things, and then eventually you'd be working with a group of people like Tamika and folks that work with her, and they'd say, mostly based on therapy, you're ready to go home, and you're going to go home next Tuesday. So we do a discharge plan for you. We'd meet with you and talk about all the things. If you have new medications, go over all that, and we'd send you home. And that would be the purpose of a rehabilitation household. Another scenario might be you're just feeling fine and dandy, and all of a sudden you have a stroke. And everyone rushes around you. We get your pendant, and off you go to the hospital, and they declare you've had a stroke. And they'll keep you in the hospital and do rehab there. And if they say you're not ready to go home yet, we'd rather you go to a real rehabilitation center to get better. You can come to this rehabilitation center. Again, heretofore, you've been sprinkled among any of the 60 healthcare beds that we have, but now you'll go to a specific area. Like a lot of folks in Richmond, they provide these kinds of services. So it'd be that kind of thing. You'd receive all the service you need. It might be that you recover, and our hope will be you recover well enough that rehabilitation and your doctor all say, it's time for you to go home. Next Thursday at 1 p.m., you're going to go home. And you go home. And that's how the rehabilitation, that's how you'd find yourself there. And that's how the services would work. You'll have medical oversight from the medical director. You'll have nurses, an RN on each shift. 3 CNAs would be there to help with things. And that's how that will work. For dining, you would have availability, you would have access to the Cedar Grill, because the Rehabilitation House is just on the other side of the Cedar Grill. If you go by the Cedar Grill in that little sitting area that's over, there's a doorway, and that door, that's where the Rehabilitation House is. So it's very, proximity-wise, very close. You can order from there. You can have takeout in that area. So it'll be a very nice place to rehab. All the rooms will be private. They'll be very well appointed. Yes, sir.
Will there be extra rehab staff or just the CNAs?
Yes, sir, the therapists will be coming into the rehab neighborhood.
Same people we have now?
And the same people we have now, in addition to, they will staff a little differently, because they will have to staff for outpatient rehab and staff for the rehab neighborhood.
Okay.
Health Pro Heritage will continue to be the rehab for the Rehabilitation Household. Well, they do it as we sprinkle you into the healthcare area. Now they'll do it in a more concentrated way. In the back, yes, ma'am.
How many hours of active therapy does one receive in this?
How many hours of therapy in this process does one receive?
The amount of therapy you receive is based on your health or your condition at the time. There's not one blanket number. They assess you and give you the therapy that's required for the reason why you're in the rehab neighborhood household.
And that would be once a day?
It could be once a day for OT, once a day for PT, once a day for speech. It could be twice a day. It depends on what you need when you are admitted to that neighborhood.
Your doctor is going to write, or the doctor here is going to, you'll probably come out of the hospital, actually. Your hospitalist in the hospital will say, I want to discharge this person and I want them to have physical therapy 3 days a week. Or they'll say, I want you to have physical therapy 3 days a week and occupational 5 days a week. It'll be whatever the doctor orders for you. Therapy doesn't do any therapy just on their own. They strictly follow doctor's orders. So whatever your doctor orders, we'll provide for you. Speech, PT, physical therapy, and occupational therapy are 3 disciplines that Health Pro Heritage provides. Yes, ma'am. In the green jacket.
Could it conceivably would you conceivably have therapy 7 days a week?
Could you conceive, will we provide therapy services 7 days a week?
Yes, because some facilities do.
Yes. We will provide therapy 7 days a week.
Okay.
Boys, a lot of went from nothing to bunches. Let's go this way. How does this impact my cost? If I have a life care contract.
How does this process you just described impact my cost?
Let's hold your question along with that one. We'll get to the finance, because it'll take us in a whole different direction. Yes, ma'am.
How many beds are going to be in the new rehab household?
How many beds will be in the new rehab household? 20.
Thank you.
Yes, sir.
If rehab unit on the 4th floor, will the rehab unit that's down here on the 3rd floor now be done away with?
If we have rehab on the 4th floor, will the rehab down on the 3rd floor, the gym, be done away with? No. Therapy will be provided on a Part A basis in the 4th floor, and Part B will continue to be on the ground floor. It's likely that even if you're under Part A, they might set you in a wheelchair and roll you down to the gym if you need equipment to have effective therapy. So both things could be happening in that same space. there's regulation that I don't quite understand about when they can happen. Medicare gets worried that you're going to double bill them, so you have to separate it out some. And I don't understand that, but Adrian understands it and James understands it. Any more on this side? This side? Was there one I missed over here? Yes, ma'am?
I was recently in healthcare and for my hip, and I didn't need to be in healthcare because you hear people down there that are crying, help me, help me, during the night, and it's very unnerving to hear people moaning, and they don't even know they're doing it. They don't even have an idea they're doing it. And I was walking back and forth all the time because of my hip. And I don't think they really understood down there what I was doing among them. I don't think they realized that what I was down there for was different. And also, well, that's enough.
So I think in a very nutshell, I think what she's saying is that her experience recently in the health center amongst folks who are more long-term care didn't feel like a good fit. And your feeling is that having a dedicated area might feel better. Is that right? Okay.
I was just going to mention that with the new rehabilitation household, you would have residents there that are there for similar things. So hopefully you would be with residents that are there for therapy and not a long-term care resident. So it would be more of a rehabilitation environment. That's the plan.
And just to be really clear about how this is going to work overall for the whole campus is this. At the end of the whole project, after all the phases of construction are done, we're going to end up with 40 long-term care rooms, 20 short-term care rooms, and instead of 42 assisted living, we'll have 65. We'll have 65. Okay? We currently have 60 long-term care. We have 42 assisted living and 20 memory care currently. When we're all done, we'll have 40 long-term care, 20 short-term, 65 as opposed to 42 assisted living, and 20 memory care. So we'll have more assisted living, fewer long-term care, and more short-term. So the idea overall is that we need to think about, and we know people would prefer if they move to assisted living to stay there as opposed to move upstairs, as they call it now. To enhance the services that we provide in assisted living, thereby lowering the number of people who are in long-term care, and having 20 rooms that will be for short-term. And that won't happen. If you were here for the director's dialogue on Wednesday, you heard me report that we currently have 57 people in healthcare. I believe on that day, 7 of them were short-term, 7, 8, something like that. It was very nice, less than 10.
Yeah.
So you say, well, Paul, that math doesn't work. And what's going to happen is that in the beginning, the new rehabilitation household will have some long-term care folks in it. Everything that's currently Poppy Place is going to move. And then over time, people, as people come and go, we'll have fewer long-term care people, and they'll be replaced by shorter-term people, and more people will be staying in assisted living with enhanced services than going to long-term care. Does everybody understand that? Yeah. I don't want you to think that on day one there's going to be a brand new place with 20 empty rooms waiting for 20 people, because that's really not how it's going to work. Over time, that's what it will become. But we will have all those 7 or 8 people that are there today will be in a place that's dedicated for them. But there'll still be some long-term care there. Over time, that will change. Does that make sense? Okay. Does that make sense to you all?
Yes, it does. It does.
I'm so happy it does. Okay. Any other questions about how it works? We can dive into the money if you want to.
We do, but we don't know what they are.
Oh, we do have questions, but we don't know what they are. Well, the main thing to remember is, if you fall, break your hip, or have a stroke, or have a scheduled surgery, and the doctors in the hospital say, I'm not sending you home yet, I'm going to send you to a rehabilitation center, and you say, I have one in my house at Cedarfield, and I'm going to go back to Cedarfield.
Mm-hmm.
You would be discharged from the hospital with that doctor's orders, whoever that doctor is. We would receive you into the new puppy place, the Rehabilitation Household, and we would carry out those orders until you got better and you went home. As is the case, sometimes a person may have a stroke, for example, and just never fully recover enough to be able to go home again and live safely. And in that kind of case, then we're in a discussion that we were in last month at this forum, which is about levels of care, how we transition between levels of care, because we have to decide what's the right place for this person to be, and does their doctor and their family agree with this? Yes, ma'am.
Can people from outside Cedarfield come and use this?
Can people from outside Cedarfield come and use this, or is it just for Cedarfield residents? We're designing it so that people from outside can come. If we relied solely on Cedarfield, we'd probably have a census of about 7 every day, short term. So we would need another 15 or so. Not 15.
13.
Yeah, we'd really need another 10 or so to get to 17-ish, 17, 18, because we want to keep something so that if you fall in the middle of the night, we've got a place for you to be. So we want to manage the census in the same way that we're managing the census today, which is we want to manage it responsibly, but we also want to straddle the line and be sure if something goes bump in the night, aka a person falls, we have something for you. If we save 2 rooms for something that goes bump in the night, and 2 things go bump in the night, we can't invent 2 more rooms. So we have to be careful about the census, but we want to manage it responsibly. And we'll do the same in the household. We're doing it now. Should we talk about money? What's the best way to do it, James? Just to talk and back in? Okay.
Good afternoon. My name is James Green. I'm the Senior Director of Community Finance and Accounting. My office is up right across from Adrian and Tamika, which is nice. So I have an office here at Cedarfield. For those of you that know me, I was a former business office director here at Cedarfield, and now I work for the Pinnacle Living office. So the first question I think I heard was Jacqueline asked, she's like, I'm a life care resident. What happens to me if I go to a short-term rehab stay? Is that correct, Jacqueline? Okay. So what would happen is that you're in the hospital, and what Paul talked about earlier was a qualifying stay. So he said a qualifying stay was 3 days. So if you're there 3 days and your qualified stay, the discharge planner at the hospital says, you can use your Medicare A benefit. Where would you like to go? To skilled nursing. Say, oh, well, Cedarfield has skilled nursing there. So you'd work with the discharge planner, the social worker, and the care team, and then you'd come to Cedarfield. So as a life care resident, when you come to Cedarfield, what would happen is that you're in independent living. It's just like today if you went to the hospital, you would still get billed for your independent living apartment. And then when you go into the rehab center, we would bill Medicare directly. So your first day, you would bill Medicare. So from day 1 to 20.
But the whole purpose of doing life care was not to be charged under Medicare.
life care is for long-term care. Does that make sense?
Up until this point, wasn't it paying for stuff anyway?
Excuse me, Jacqueline, sorry.
Wasn't it paying for things anyway, even if it was a short term?
Correct, but you were doing a short-term Medicare stay. That's the difference. If it's a short-term Medicare stay where you went to the hospital, it was a qualifying stay, and you come back and you're going to use your Medicare benefits, you would go into the Medicare rehab area. And then from day 1 through 20, we would bill Medicare. And then from days 21 to, I believe, 100, then there could be a copay that's processed through your insurance company. So Medicare is going to say, okay, after the first 20 days you pay 0, and then from day 21 through 100, if you have insurance or a secondary payer for copay, then you might have a copay obligation. But Medicare will bill your secondary insurance company.
At what point does it get to be considered long-term care?
So under Medicare, if your stay is based on your condition, so how much, like Adrian said earlier, someone asked the question, how much therapy am I going to get, or what treatments am I going to have? So she talked about you could have PT, OT, speech therapy. So depending on your care plan, and then when you're discharged from that stay, then you can be discharged back to your house, back to your independent living.
There's an important term that Medicare uses called plateau. And so when a person is getting better, progressively getting better, their stay continues to be covered under Medicare. When they plateau and they're not able to get any better, then their Medicare ends because it's no longer rehabilitative, because you're no longer able to rehab. For some people, for most people, that rehabilitative plateau keeps going until you're ready to go home. For others, like a stroke, for example, you might rehabilitate to a certain point, and so much damage might have been done to your brain in the stroke that you may never be able to fully recuperate, and you plateau at a lower level than you can safely live independently with. So it's all about rehabilitating up to, and when you plateau, the therapist will continue to work and continue to work, and eventually they're going to say, this, in our professional opinion, along with the doctor and the staff, is we think this is as good as this person's going to be able to be, then we'll consider plateau to be in Medicare services.
Right, so in that case, say you still needed long-term care, you would be discharged to one of the other neighborhoods, to Magnolia Meadow or to Lavender Lane. So that's why it's talked about it's a short-term rehab stay, so you would be discharged to a different neighborhood. Yes, ma'am.
And you would have to pay a copay after that plateau, is that?
No, if you're a life care resident, you would be permanently transferred in this scenario to health care to another neighborhood, and then you would move just like you move through the continuum right now.
So the life care would pay?
Correct. Your life care, your fee would stay the same, correct.
Where do long-term health care come in this scenario?
Sure, so let's talk about that. Let's talk about long-term health care. Oh, okay, so the question is, how does long-term care come into play in this scenario that I just said? So long-term care insurance is a policy that you have, as an individual or a couple, and you have it with a long-term care insurance company. Some of them have a 30-day, 60-day, 90-day elimination period is what they have for that. So they might pay, I'm just going to use an example of $200 a day. So it says that I'm going to use a 0-day elimination policy for 5 years, $200 a day. That's your policy. So if you're in like long-term health care, then you can file a claim with your long-term care company. The long-term care company pays you directly, and then that money goes directly to you.
So we could use that to pay for an aid or anything else we would need.
Correct. She said that, well, if I have that extra money, since I'm a life care resident and my fee's not going up, I could use that money to pay for an aid or someone else to help me. If that's your money, you can do with it what you want with it. But that's correct.
So if you don't have a long-term care policy, what would the situation be?
So if you don't have a long-term care policy, you're a life care resident, and you move to health care permanently, your fee still stays the same from what you're paying in independent living. It doesn't go up.
But if you didn't get any private duty or anything else, that's extra?
You're correct. So the question was, if I wanted private duty while I'm in long-term care, since you're requesting that care, that would come out of at your expense. Okay, so we talked about life care. So let's talk about another agreement that we have here at Cedarfield called Preferred Choice. So if you're a Preferred Choice resident, everything that I just said is very similar. So if you go into the rehab center, you go into the hospital, you have a 3-day stay, qualifying stay, you come to Cedarfield to the rehab center, the same thing applies. We bill Medicare, and then for the first 20 days you have a zero copay, and then after that your secondary insurance and copay to 100 days would take into effect. Everyone follow me so far?
And after that,
and then after 100 days, if we use the same example that Paul says, that now I need to be discharged, I still need care, I need to go into health care, then you would be discharged and transferred into Magnolia Meadow or to Lavender Lane, and then you would pay the per diem rate for health care. So Medicare A just is short-term rehab. So that's what Medicare A is, and that's the situation that we're talking about. So anything from 1 to 100 days short-term rehab, that's under your Medicare A. Some of you are using Medicare B benefits, which is outpatient rehab, and that's what you're doing through Health Pro Heritage. That's what Medicare B is. So what we're talking about today is Medicare A. There's one question up front.
Is there anything you can share about the impact of if you have an Advantage plan?
Okay, so she's asking about what would be the impact if I have a Medicare Advantage plan. So that would be Medicare C. So that's a Medicare Advantage plan. So as a startup, right, we're starting brand new. Currently, right now, we do not take Medicare. So as a startup, currently, we do not have any agreements yet because we're not certified as Medicare with Medicare Advantage plans. So there are so many different types of Medicare Advantage plans, and they all cover a lot of different things. But until we have agreements with the Medicare Advantage plan, we would be considered out of network. So depending on your plan and what your plan covers, you have to say, okay, what does my plan cover if I go to a skilled rehab center under Medicare Advantage plan that's out of network or not participating? It depends on your plan. It could be that if it's out of network, they'll cover nothing, they'll cover zero, and then you would be responsible for paying the fee there. But if you were a life care resident and then you were there, then you wouldn't have a fee.
So that's very confusing. The difference between Medicare, I'm standing behind them. I feel suddenly like I need a protection. The Medicare, traditional Medicare, parts A, B, and D. In the 90s, you got D, which covers your drugs, is oftentimes referred to as traditional Medicare. And sometime in the 90s, I guess it was, they introduced Medicare Part C, which is the Advantage plan. And basically what it does is it allows companies, all like Aetna and Humana and what's the one that starts with a K that's so difficult to deal with? Kaiser, all those plans, Medicare said, we're going to allow you the opportunity to take our exposure for every Medicare person we have, give it to you, and any person that wants to sign up for that, they can move away from our traditional Medicare and come with you and do your plan, and we'll pay you to take their life, to cover their life. And that's what Medicare Advantage is. Basically, the government says, on average, we spend $1,000 a year on every Medicare beneficiary we have. So they go to Kaiser and say, hey, Kaiser, we're spending $1,000, we'll sell you that life for $800. So we're spending less Medicare, we're saving the taxpayer money. Kaiser says, well, I'll do that. I believe I can cover them for $800. I believe I can cover them for $600 and make $200. And so that's what Medicare Advantage is. You assign your benefits over to an Advantage plan. And so what we're doing is we are working on an agreement with the federal government to provide traditional Medicare. And that's what the process that Tamika and Adrian are very involved in getting us certified. It ultimately ends with an agreement that says government's going to pay us for your services, and then we're going to meet all their quality and all their other regulations. In order to participate in an Advantage plan, every provider like us has to decide they're going to, and they have to go to Kaiser or go to Humana or go to Aetna and say, we'd like to be a provider for you. And then the provider has to decide, do we need you? Do we want you? We may not need you. If they say, yeah, we do need you. We'd like to have you in our network. So then they'll say, well, here's a contract. And you have to sign the contract, and here's how much we'll pay you, which is going to be different than traditional Medicare. Remember, this is all about saving money. And the length of time we're going to cover is different. Medicare will let you stay 100 days. Kaiser may say, we'll cover you for 14 days, and that's it. So that's the deal with Advantage, and we have to decide whether we want to ask to be in those agreements, and if we do, which ones, and what are the conditions that we want to participate in. So it's a whole different ball game with Medicare Advantage. Currently, as James says, we have no contract with any Advantage provider. We're just simply trying to get to be a provider for Medicare first. And then after that, we'll figure out what we want to do for Advantage plans. I think the main thing is I think I'm saying this right, James, is for preferred choice contracts. A preferred choice contract currently pays independent living fee, goes to the health center, they pay the going rate for the health center. If you have traditional Medicare, then your state can be covered under that. If you don't have it and you have an Advantage plan, we currently don't have an agreement with any plans. So you'll have to decide whether you want to come back here and pay the full rate, or do you want to go somewhere else that does take your plan and be covered by that plan. Did I say that correctly, James?
Yes, that's correct. You did say that correctly.
There's a lot of those Medicare Advantage plans around. There's nothing wrong with them. They're just different. You have to understand what you bought.
And they also vary by what you could have Kaiser, but you had Kaiser from your employer. Somebody else might have Kaiser, but their benefits could be a little different based on if they got it from their employer. So that's why I said each individual plan. If you have an Advantage plan, you want to make sure you understand what it covers.
Because it's different. Medicare Advantage, again, the government, I'm just making this up, $1,000 per life of what we spend every year. They're going to say to Kaiser, or one of them, we'll sell to you for $800. We'll save the taxpayer $200. Kaiser says, well, got to profit some, so I'll take the 800 and I'll spend 600. Again, just making these numbers up. But I'm going to spend no more than 600 because I got to make two. I got shareholders to take care of. So that's what they want to do. So the main way they're going to do that is emphasize preventative care for you, which is good, and limit your exposure, their exposure to high-cost areas like hospitals and nursing homes. They want to limit that. They'll get you home, they'll get you, try to keep you safe, they'll provide you drugs for free so that you never fall off your maintenance drugs because they want to keep you well. That's their main charge in life. Because everyone they spend $200 on, they make $600. Everyone they spend $1,000 on, they lose $200. So that's what they want to do. Sorry, I started preaching there, didn't I? I'm sorry. I won't pass a plate.
Yes, Jacqueline, got one more question.
Are we going to be able to have the option of our private physician come if we're in on the Medicare wing?
So the question is, will we have the option to have our private physician come as our doctor in, are you specifically saying the rehab area or anywhere? I'll let Adrian answer that.
Are you talking about just rehab or?
Initially, yes.
Okay, so there is going to be a credentialing process that Medicare goes through, and if they pass the credentialing process, then they're invited to come in, pass credentialing through Medicare and credentialing through Pinnacle Living. So the answer is yes, as long as they're willing to submit the paperwork and be approved. It's not an automatic approval. Make sense?
Right.
Okay.
Okay, and what is different between the other areas, or is the same things apply?
The other areas don't have to go through the Medicare certification part, but they do have to go through the Pinnacle Living certification part.
I have a question. How are we going to make money on people that are coming from the outside with the student? If everything is being billed to Medicare, how are we making money?
So the question is, like, if someone comes from the outside, how does Cedarfield generate revenue from that patient? So let's use this side of the room right here. Let's imagine that this side of the room, there's roughly 20 people. Let's say there's 30 beds for the 20 people. So right now there's 10 empty chairs, so that's 10 beds. So every day that chair goes empty, that's lost revenue. So there's 1 chair, 2 chairs, 3 chairs, 4 chairs. So if those are beds and those beds are empty, then that would be lost revenue. But if someone, right now if we have availability and you have those beds available, then, you know, we looked at all of our population here and we said, okay, does anybody at Cedarfield need these beds or chairs? And we say, no, we don't see anybody here. Does anybody on the Pinnacle Advantage plan need those beds? And we look around and we go, no, no one needs those beds. And then we say, oh, those beds are empty. So there's no billing for those beds. But we say, aha, we can fill that bed with someone that's at St. Mary's and they just had a knee replacement. They'll probably need maybe a 20-day stay, do some rehab, and they could fill that bed. Someone else could fill the bed with a hip replacement. Someone else could fill that bed. Could say they're doing a different type of rehab. So by keeping our census at a full level, then we could generate revenue by keeping our census up to date. And then with a higher census, that means more revenue for Cedarfield, and then that's less pressure on all the other residents, you know, for revenue when we're doing budgets and to lower your monthly fees.
I still don't see how that, her question, that answers the question.
So if we have available beds, and no one here can fill them at Cedarfield, but we can get someone from the outside to fill that bed, we're charging that person from the outside.
Above and beyond what, say, they're being billed Medicare?
No, well, Medicare pays Cedarfield.
Yeah, so this is how it works.
That's where we're trying to get
Okay, so Medicare, when I say build Medicare, what that really means is Medicare is going to pay Cedar Field. That's what that means.
Yes. Medicare is going to give us a blended and aggregate rate for the services that we provided, and it changes quarterly? Quarterly. Quarterly, the rate that they'll pay us changes. And every, I'll use the word facility, but every rehabilitation facility gets paid a different rate because they provide different services. And so if you do more medically complex things and it takes more supplies and it takes more people and it takes, Medicare tries to recognize that and pays you back a higher rate. If you're doing very low cost things, they'll pay you a lower rate. And that's good. That's the government trying to save you money. So the trick is for us is to be able to capture the things that we do for you in a form. It's very complicated. We don't have to get into it, but we ship it off to the government every quarter, and they take it all and they send us a letter, and our little letter says, "Hey, guess what? Your rate per day for this quarter is $700," and they'll pay us $700 for every day, and that's a whole lot better than an outside where our current rate is $400. So Medicare pays you more to the tune of $200, $300, $400 a day more when you participate. So it can be, if done correctly, a good source of non-independent living resident revenue.
Right, to follow up on a question earlier that Dr. Seghetti had. She asked about the ratios for RNs and CNAs, and the way it's staffed in the budget is to make sure that it's a Medicare 5-star rating. And then there's also an inspection piece that's done on that, and when they come in, inspect the community, and then based on that star rating, which has another metric for your reimbursement rate. And then as Tamika said, you only need 8 hours but for RNs, but we're going for 24 hours, so our RN to patient ratio will be a lot higher, and that also increases your reimbursable rate. But it's really also to provide the care level as well that's needed.
Is that 7 days?
Yes.
Yeah, 7 days a week, yes. Yes, ma'am.
If I go to the hospital and it's not a qualifying stay, so they will keep me 1 day, am I allowed to come back to the rehab hospital?
So the question is, if I go to the hospital for 1 day, can I come back to the rehab hospital? And so it depends on the payer is really what I'm going to talk about. You can't come back, but your question is would Medicare pay for it? Medicare would only pay if it's a 3-day stay or there's some sort of qualifying exemption that you might be able to get through COVID-19, for example, where you could, in the current environment, you could ask for a waiver under COVID-19, but we don't know how long that's going to keep going for. But historically, if it's less than 3 days, and you wouldn't be a qualifying Medicare stay.
But will I be allowed to use the rehab house for care?
Yes, you would be allowed to use that under life care if you didn't have a Medicare stay.
You could, but it'd be unlikely if you only had to stay in the hospital for 1 day that you would really need that kind of rehabilitation service. It's more likely you'd probably get discharged home and have some home health with affirmation or some other home health provider or something like that. But in the case that you really needed to be in a rehab house with a 1 day stay, you could. There's nothing that says you couldn't. It's just a little unlikely, and you'd probably rather go home anyway.
I'll give a personal example. Last July, my dad fell, and so he had a qualifying stay. He was in the hospital for 14 days, and then I had to go through care.com and compare.com and look at all the different skilled nursing communities in Ohio, and my brother and we did a couple visits to a couple of them, and then like, okay, we're going to send Dad here. So we send Dad. He stayed under his Medicare A stay, and then he got sick again, so he went back to the hospital, and then said, okay, we're going to discharge them again and send them back to Medicare, stay, and then, so then they send them back to the rehab center. And then the rehab center says, your dad's not getting better. You know, he's not, you know, your dad needs long-term care. He doesn't need rehab stay. So then we just changed. We said, okay, we're going to end the Medicare stay and we're going to go to private pay. So I worked with the billing office. I said, okay, the Medicare stay is over. Now we're going to go to private pay. And then I went to private pay because the Medicare stay, it just, the rehab just wasn't for my dad. He needed long-term care. Yes, sir. Okay, he's going to give me a hypothetical.
You have, for the Medicare unit, you have a 20-bed capacity.
Yes, 20-bed capacity.
15 beds are taken up by Cedarfield residents, or 5 by Cedarfield residents, and 15 outside people come in and stay. Okay? Okay, the unit's full. What if all of a sudden Cedarfield has 3 residents who need to go into the Medicare unit? Are you going to bump 3 of the outside days to accommodate Cedarfield residents?
Okay, I'll repeat the question. The question was, if your census has people from the outside and Cedarfield residents, say it's skewed where you have 5 Cedarfield residents, 15 outside residents, so now you're at 20 beds, you're full, where's someone going to go at Cedarfield if those rooms are full? If you need 3 people, go bump in the night, what will happen? And I'm going to transfer that to Mr. Paul.
Yeah, and specifically said, would you kick somebody out, basically? I think the answer to your question is that we do that, we manage the census the same way today, whether it's with Medicare or not with Medicare. We currently take outside admissions into our health care. I think everybody knows that. They happen to be long-term care folks, but we do take them. And we somewhat rely on them to manage our census effectively. So we're accustomed to managing the census in a responsible way, and this is really no different because we have people coming in and out from a short-term basis all the time. Specifically, would we kick anybody out? The answer is no. We would not kick someone out onto the street if we have assured them that we would have care for them. The basic question really is, if the health center is full, what are you going to do? That's the question. And I feel like we've talked about that a lot. We talked about it a lot at the last session, and I've covered it a few times in the director's dialogues too. We will do whatever we need to do to make sure you get the care you need. So, if the health center is full, if it's 60 today, it's not though, it's 57. It's 57 today. Well, let's say it was 60. And then tonight someone fell and went to the hospital and we were still at 60. So we would start figuring it out quick. There might be a couple rooms in assisted living. And maybe we go to assisted living and then we hire some staff to help you and we pay for it to make sure you get what you need. Maybe where there's someone who's close to discharging, they weren't quite ready yet, maybe we go to that person and say, hey, can you move down to assisted living because you're close to going home anyway, and bring you in that room. So there's a lot more. Maybe you go home and we hire help for you. And there's any number of things that we can do, but we're not going to go, oh, sorry, I can't help you. We're going to really work hard to be sure we get you the care that you need. It's certainly possible, and I'm sure it's happened here sometime in the past. It's happened to me in my career many times. Sometimes you plan, you have 3 beds, and 5 people go to the hospital. You can't help that. But we're not going to run 10 empty beds all the time. You do not want me to run 10 empty beds all the time because you can't afford it. They're worth about $150,000 a year each. If we got 10 of them, that's $1 million in lost revenue that you really don't want to make up in your monthly service fees. So it's on us to help you by managing it responsibly.
Any other questions? If you think of a question, you're like, oh, I don't know. My number is 8789 is that right? 8789? I'm still trying to learn my new number. It changed. I had my old one memorized, and they gave me a phone number that accidentally was Sharon's old number, and everyone was calling me about housekeeping. I was like, oh, I need a different number. This one's not working. Anyway, well, thank you very much for taking the time.
And how about a round of applause for our panelists? Thank you, James.
Thanks, James.
That was swimming with me. That was one single slide.
Sorry, I'm stuck. Bottom line, continue to care. If I go, Medicare is going to pay part of my bill. What happens to my monthly bill?